Okay, our final speaker, who'll wrap up the session, will be Roger Staff, who's from the University of Aberdeen and the Natural Health Sciences, and he's leads the physics imaging team at the institute there. So, Roger, you'll be talking about early life conditions on late life accumulations of pathological burden and cognitive decline, findings from the Aberdeen birth cohorts. Thank you.
So it's been an advertisement for Scotland is the place to come for life course studies. I'm going to talk about the data, and Stuart talked about the 36 cohort. There was actually a cohort that preceded that 15 years earlier, born in 1921, that were tested in 32, and in Aberdeen there is our biggest cohort called the children of the 50s. I'm going to talk about early life and brain pathology and cognition and cognitive trajectory, and then I'm going to talk about some of the difficult things we've already talked about here about selection, retention, practice effects, and analysis of resilience longitudinally. So life course, we start off in early life and we accumulate our potential, our cognitive potential, and there's individual differences between people, and then we move forward into aging, and at some point we hit this point of inflection, or perhaps it's just a smooth decline into aging, and we decline, and some of us end up demented, and some of us die before we're dementing, etc. Okay, so 1921, just to reiterate, they were born in 21, part of the Scottish Mental Health Survey, which was brought about just after, they tried to initiate it just after the First World War, but it didn't happen until 1932. We've traced them in Aberdeen. We didn't advertise in the paper. We traced them through the local health index and then got their general practitioners to approach them. So our recruitment method is significantly different from other more common ones, which is to advertise in the paper and promote locally. Again, we've done 1936 as well. There's a follow-up study, and this is the study that I'm currently involved in, and probably more in terms of the numbers. This is the Aberdeen children of the 50s. Here we've been able to link the data to the Aberdeen maternity database, which is essentially if you were born in the Aberdeen maternity hospital, we recorded all sorts of information about you and nutritional status of the mother, etc. They've been followed up a number of times since the 50s, and we're currently going through a phase of recruiting 500 and imaging them in much the same manner as we've done with 36 and with 21. So I'd like to talk first about socio-economic advantage, and in as much that this is where we start life. And between the three cohorts, we've got a group that actually went to war, but born in 21, grew up in the Depression. Then we have a group that were born just before the Second World War and grew up after that. And then we have another group born in the 50s that experienced the oil boom. So there are three different cultures, groups over the 20th century. So one of the things we looked at was white matter hyperintensity, the accumulation of these white matter burdens. And Stuart showed you some nice pictures. The scale along the bottom here is essentially looking at the socioeconomic position of the father, and that's classified through father's occupational class. And we get a rough division between the lower end and the upper end. So if your father was from a lower socioeconomic strata, then in late life you appear to have more of this white matter burden. Yeah. We also looked at hippocampal volume, and we're very much telling the same story in as much that you have a smaller hippocampus if you're from that lower strata of society, in Aberdeen at least. Now, the question we asked at that point, is this, what we're looking at, is this differential decline or is this differential development? And there's evidence from the PING database, which has also been mentioned, from Kimberly Noble at Columbia, where she's actually plotted brain, in this case it was cortical surface area versus income, and you see that at the lower end there's a differential brain development. They have smaller brains at the lower end. Interestingly, this is not produced in the Scandinavian cohort by my learned colleague to my left, and the pretend amateur sociologist in me saying, well, is this the same as, is this evidence of 50 years of the welfare state in Scandinavia, which is strong and been in place for a long time. So within our data, we've made this connection between poverty and differential development, late life cognitive decline, and risk of dementia. So we've followed our group up to whether they demented or not. Hippocampal volume, as you're probably aware, and rate of hippocampal shrinkage is associated with the onset of dementia. So these white matter lesions, and by and large in normal practice, a few of them are just regularly ignored in normal practice. They're not accumulated in early life, so they're a late life manifestation of this disadvantage. They're associated with cognitive ability in late life, they're associated with vascular risk, as I've shown, they're associated with socio-economic burden. They're not associated with the trajectory of decline. So if you have lots of them, it's not associated with the trajectory that we went after follow-up. And they are not, in our group, associated with our dementia outcomes. So this is a result from our children of the 50s data, where we looked at early life birth weight, and particularly low birth weight. What we saw in the children of the 50s, we have an additional advantage that they were tested at 7, 9 and 11 with the Murray House test at age 11. And we see the disadvantage of a low birth weight in early life appears to be disappears. They have this catch-up phenomena by the age of 11. But when we look at them at age 55, we're still seeing associations between early life birth weight and particular cognitive tests. We've talked a lot about how various measures in early life, education, occupation, childhood, socio-economic advantage interact. Now, we've said these things that a clever child will get more education, so will a richer child get more education. So there is structure in this data, and the simple long linear regression really doesn't capture that type of interaction. So here's this model looks at the positive effects, so a good occupation, which didn't come out positive in our study. And on the left-hand side is the burden, the accumulation of white matter lesions and hippocampal atrophy. And they're all associated with our late life general cognition. One of the interesting findings that we had was to look at early parental death. So if you had a traumatic event, and the death of a parent is obviously traumatic, before the age of 11, what impact did that have on you in terms of your dementia outcome? And we've looked at this with and without APOE, we've factored in education, childhood intelligence, etc., family history of dementia. And what we found is that an early parental death in this study, in this sample, was equivalent to the risk of APOE. So it appears here that this trauma in early life, the toxic stress of bereavement, may well be influencing your risk in late life. We've touched on selection biased, what advertising in the paper gets you in terms of a sample. And because we have the early life, because we have early life IQ, we can compare those that said yes to us and those that said no to us. And lo and behold, the smarter ones said yes to us. Because we have their postcode, and there's a very useful index in Scotland called the Scottish Index of Multiple Deprivations, and it essentially establishes your socio-economic class based on your postcode, where you live. It was the richer ones that appeared that said yes to our study. When we look at retention in our study, it appears that our group gets smarter. If you come back, you're generally smarter to begin with. If you come back, you are generally richer to begin with as well. So we've got this biasing going on in our longitudinal study in terms of baseline ability and in terms of socioeconomic position. There's also this effect of practice. So this spaghetti plot is all our data for AVLT, and the plot on the right-hand side is essentially the first 10 subjects that we looked at. We find that there's a significant practice effect in what we do, whatever test that we do, with the exception of digit symbol, which appears to be invariant to practice. It's quite a big hit. AVLT was 4.5 and Ravens was 2.3 in terms of this practice gain, this initial bump in the data that needs to be accounted for when you're doing these longitudinal models. The way we did that was to use an initial practice model whereby which all the gains between the first testing and the second testing were compensated for over that, and after that you start to see a decline. Now, we've talked about proxies of reserve and we've talked about resilience, etc. Your practice gains are associated with what we consider to be a proxy of reserve. In this case, it was education. There's variance in the amount of practice that individuals can achieve, but we got quite a big hit from those that were well educated compared to those that were not. The final issue that we come across is essentially that there may well be a regression to the mean after they were tested first. And I'm not really entirely clear about we find this covariance between the intercept and the slope with age. I'm not entirely clear about what's going on here, whether it actually is in a regression to the mean, or this is that coming in and scoring well at your baseline test is actually a risk factor for more decline. So, after introducing all these practice effects and adjusting for multiple types of socio-economic position, we looked at the life course socio-economic position with childhood and an interaction between age and education. We found there was no interaction effect between age and socio-economic position in childhood or in adulthood, but there was this age-education interaction. And again, this may be self-selecting. As I mentioned before, it may well be that people with lots of education tend to remain in the study. One of the previous speakers this morning talked about Clotho. We never found an association between Clotho and cognition per se in our sample, but we did find an age by Clotho interaction. So it may well be that the effects of Clotho may only be seen in late life. I was unclear about what the age group was examined earlier on today, but I'd like to follow that up at some point today. Finally, in some ways, I feel that simply looking at cognition in isolation as your outcome measure, without looking at the other health gains or health outcomes, depression and physical fitness in what we got in this model here, is probably a bit misleading in as much that the people will score less in cognitive function tests if they're depressed, and there's a relationship with physical fitness and depression, etc. So here we looked at occupational profile mixed up through via the job itself, whether it was complex in terms of data or was it people managing complex, what the categorization in terms of employment stress was, or what the professional status of that job actually was. So here we're looking at childhood IQ, and we've gone down the trial of impairment route in as much as trying to look at our data in a number of ways. After examining this, there appears to be no independent associations between those factors on the left and those factors on the right that would improve the fit of our model. So summarizing our data using these data reduction techniques may well be the way forward with big, large data sets. Finally, I'd like to acknowledge my collaborators, Alison Murray and Lawrence Wally in particular. They've been involved in this project for the last 18 years, and they will be involved with the children of the 50s probably for the next 18 years. And they've been a pleasure to work with over the last wee while. Thank you very much.
Okay, thank you so much for the perspective and interesting findings. Questions, please?
I'd like to ask a question of Dr. Volovic. In the United States, we use the APGAR score. Every infant gets an APGAR score, 1 minute and 5 minutes. You don't see many people saying, I was a 10, what were you? And relating to your data, how do you see us continuing to use the APGAR score as a rating score for infants and prognosticating for their future health?
I don't think that my data speak against the use of the APGAR score. I think, to be honest, I think that there was maybe too little variance in the APGAR score in this particular sample. There was variance, but as you saw, we had, for instance, very few children who had very low birth weight. And so most of these had a relatively high APGAR score. I think the average was like 9 or something, yeah. So I think, I don't think that this speaks against the value of the APGAR score. It was, certainly this is something that I would like to look at in broader cohorts as well. And then it could have a different predictive value. But we'll see.
You have a question for Roger?
Yes, I do. Have you looked to see if what kind of cohort effect between your different cohorts? Because certainly people who were born in the 20s have very different childhood experiences than those of us who were born in the 50s and so on. So
I've looked at a comparison between 21 and 36, and we have got clear Flynn effects between the two groups. There is a gain of about 3 or 4 IQ points, which is what we'd expect. Just expanding on the Flynn effect, if you're going to do a cross-sectional study where you recruit everybody between 60 and 80, you're going to expect a difference just through Flynn to begin with. So that slope may well be just a Flynn slope rather than an actual decline across that group.
Yes, please.
The single child, multiple child has any difference?
We have that data about where they were in the family, whether they're the first child, etc. We have looked at it, but nothing has really shone out in terms of the first child doing better than the second child. There is lots of literature that say that may well be the case, particularly amongst boys, but we don't see that.
Can I ask?
Mm-hmm.
Sure. We'll have Carol go next.
So it's really a question both for Roger and Christine to kind of unpack for us the differences in your samples, where you're getting one thing in Norway and another thing in Scotland, in terms of the younger kids growing up.
We're dealing with adults above 50. The childhood experiences were retrospectively acquired. So essentially we asked them, so what did your father do when you were a child? So that essentially is. We asked them whether how many public rooms that were in their house, where did they live? Because there's a certain amount of historical data that says that if they lived in the west end of Aberdeen, was the place to live. It was the rich part of Aberdeen. So we have those types of data. For example, we asked them whether their sanitation was in or outside the house.
Should I comment now?
Yes, please.
Yeah. So I think that there are part of these differences have to do with different measures, but I also think that there are likely some real between nation differences in the impact of these variables. And this has recently been shown. I think we talked about this in these meta-analysis by Tucker, Drobe, and Bates, where they showed that there were national differences in gene socioeconomic status variables interactions, where you found some. I think they compared the U.S. to other countries. I don't remember exactly which. We talked about this right before. So there are probably some true differences in what these socioeconomic status variables actually are a proxy for, because that will vary with your society and also vary across time, of course.
I think that the Katie Pickup book on inequalities between societies is probably maybe what if we ask the same question in different countries, it will mean different things.
Sanjay, I guess we can put your thing into the general discussion or
Sure.
this one, either one. No, I think we have time for one more question.
You know, in regard to your SES data, I wonder if you have an ability to look at neighborhood disadvantage, whether that concept you're familiar. You know, in the US, you can literally geocode every neighborhood and find out what is the extent of disadvantage in that neighborhood. And some interesting correlations are coming out between neighborhood disadvantage and dementia risk and cognitive outcomes. And I wonder if you have that ability in Scotland to do it.
I agree with your point that there is probably inequalities due to at the personal level and at the regional level. We don't have the neighbourhood apart from what we can extrapolate from the historical data, particularly in children, but we do have their school. And the samples from the school, we have 15 or 16 individuals from the same school. And there is about 10 or 11 where we have enough to look at. And there is variance based, if you used to do a multi-level linear model, there is variance at the school level as well as at the individual level. And I think that makes your point.
Yeah. And, you know, these are very modifiable factors, so I think it has a major impact on public policy, health policy, and the outcomes could be quite important for the country as a whole.
Okay, thank you. Good comment.